Good afternoon, everyone. As you begin to join us here, we are excited to welcome you to the Cancer Prevention and Early Detection for Community Health Centers webinar series. Um, as we come to the close of Cervical Cancer Awareness Month, we're excited to have you with us today to share about promising practices to increase cervical cancer prevention and early detection. Next slide. My name is Anne Gagliotti. I'm a family physician and serve as the Vice President of Implementation Science here at the American Cancer Society. We do want to let you know that this session is being recorded um, and that the recording and the slide deck will be available to share with you all in a resource roundup next week. Next slide. Um, To start out, we do have a quick poll for you to complete. And as you are working on answering those questions, I'm just going to walk us through the agenda for today. So we'll have a brief welcome and orientation here, and then we'll hear from Dr. McLaughlin about the current state of cervical cancer and promising practices of self-collection. Our learning objectives for today will be focused on the following. Understand the burden of cervical cancer in the United States, as well as understand the impact of social drivers of health on the uptake of cervical cancer screening. And finally, we hope you'll be able to understand the evidence and effective implementation strategies for HPV self-collection. If you do have questions throughout the webinar, I encourage you to ask those in the Q&A function through Zoom. And then we also encourage you to post your comments in the chat box as well. Next slide. We're very excited to have two wonderful experts with us today. Dr. Kathy McLaughlin, who serves as an associate professor of family medicine at Mayo Clinic's Family Medicine Residency Program. She co-chairs the HPV self-collection group for the ACS National Roundtable on cervical cancer and recently was appointed to the Roundtable's steering committee. Previously, she co-chaired the ITEHR group for the ACS Primary HPV Screening Initiative. She has also served as a subject matter expert for NORC in their work with the Federal Cervical Cancer Collaborative on the Cervical Cancer Moonshot Roundtable series, and with HRSA's Office of Women's Health Cervical Cancer Echo Learning Series for safety net settings.
Thank you. Good afternoon. Happy Cervical Cancer Awareness Month, everyone. Thanks for calling in for the webinar. I'm really excited to share information with you today on HPV self-collection for cervical cancer screening. Next slide. My goal is that following this presentation, you'll have a greater understanding of the burden of cervical cancer in the United States, along with awareness of the social drivers of health and socio-demographics that are associated with lower screening rates. I'll also briefly touch on current screening guidelines and proposed updates, but intend to spend most of the time talking about HPV self-collection. Next slide, please. To that end, the presentation, other direction, please. Oh, okay, sorry. I have another slide in the deck that you don't have. Apologies for that. Okay. Cervical cancer, go ahead. Not running your own slides. Okay. Cervical cancer rates have decreased by more than half in the US since the mid-1970s, but cervical cancer still causes disease burden, frankly, especially at global levels in low and middle income countries. But what we have pictured on the slide here is the 2025 estimates from the American Cancer Society that includes just over 13,000 new cases and 4,300 deaths from cervical cancer in the US in 2025. This translates to incidence of 7.6 and mortality of 2.2 per 100,000 people. The real issue is that cervical cancer is preventable, as Dr. Perkins shared with us, starting with HPV vaccination and then continuing with regular recommended screening and follow-up and treatment of precancers. Most cancers occur in those who are never screened, underscreened, or don't have the appropriate follow-up or treatment of their abnormal results. And concerningly, when we look at the National Health Interview Survey data from 2021, there's been a steady decline over the past 20 years in terms of self-reported up-to-date status for screening, with about 25 to 30% of screening eligible people not up to date as of the 2021 survey. Next slide, please. We do want to acknowledge today that many of the health disparities we see are related to social drivers of health, as pictured here, rather than biological factors. When people don't have access to the resources that they need to protect, improve, and maintain a high quality of life, that may result in unfair and unjust cancer disparities. Next slide, please. These next few slides I'd like to go through relatively quickly so that we have plenty of time to discuss self-collection. But I wanted to share that this is data, again, from the 2025 National Health Interview Survey, showing the associations between different socio-demographic characteristics and cervical cancer screening rates. So the first slide is showing differences by race and ethnicity in screening. I do want to acknowledge that although screening rates in this particular data set were higher among Black women in 2021, other studies have shown concerning findings of higher rates of squamous cell cancer and higher mortality from adenocarcinoma among Black women. Next slide, please. We can also see that the likelihood of being up to date with cancer screening increases with higher levels of education. Next slide. The likelihood of being up to date with cancer screening just slightly varies if we look at geographic US region, but this data isn't capturing the known differences in screening rates between rural and urban populations, with generally lower rates found in those rural settings. Next slide. The likelihood of being screened increases with the family's income level. Next slide. And not surprisingly, the likelihood of being up to date, changes by insurance status, so that folks who do not have insurance are the least likely to be screened, with some improvement with Medicaid or public insurance, followed by private insurance. Next slide. This slide is really just providing a high-level review of the current average risk screening recommendations from USPSTF, ACS, and ACOG. Essentially, USPSTF and ACOG follow the same recommendations to start screening at 21, with pap testing every 3 years until 30, and then with the option to switch to HPV-based screening, such as co-test or primary, every 5 years. The two key differences with the ACS guidelines, which were last updated in 2020, include the starting age of 25, given the low cervical cancer and disease burden under that age, and a preference for primary HPV screening every 5 years starting at 25. All the groups agree on the exit criteria, which is perhaps a bit out of scope for this talk, but suffice it to say we aren't great at ensuring that we as clinicians have made sure it's safe for our patients to exit screening. So I encourage you to look up those recommendations, or we can talk about it in the Q&A as well. Keep in mind that these guidelines were drafted prior to the approval of self-collection HPV testing, and the USPSTF issued draft recommendations last month, preferentially recommending primary HPV every 5 years for 30 to 65-year-olds, while still allowing for PAP and co-testing as ACS has done, but they did not distinguish between clinician versus self-collect. Please note these are still draft recommendations. Next slide. All right, now we're going to jump into what you probably really want to hear about, which is HPV self-collected testing. Next slide. So HPV self-collected testing is basically an alternative way to do primary HPV testing. The same PCR test is done to evaluate for the same types of HPV. The difference is that the self-collected test is run on a vaginal sample, whereas the clinician-collected test that we're more familiar with is run on a cervical sample. This screening test option was approved by the FDA in May of 2024 for use in a healthcare setting, not in a home setting, when the patient has a barrier to a speculum exam. The intent is really to expand the menu of cancer screening options and increase screening rates by addressing barriers to a speculum exam. Other options are not going away. Next slide. Multiple studies have been conducted to evaluate the accuracy of self-collected HPV testing. Specifically shared here are results from 3 meta-analyses by Arbin et al. That showed the following. First, that self-collected HPV tests are more sensitive than a clinician-collected PAP alone to detect precancers and cancer in the first round of screening. Second, that self-collected vaginal and clinician-collected cervical HPV results show high positive and negative percentage agreement for the HPV result itself. And finally, that self-collect has slightly lower than, but near comparable relative accuracy to clinician-collected HPV testing to exclude and detect precancers. Next slide, please. So how is the HPV self-collection done? Well, as I mentioned earlier, the FDA approval, which came out in May of 2024, again, I want to reiterate, is for in a healthcare setting, not in a home setting. But for eligible patients who choose this option in the clinic setting, they would be given the device with instructions for the self-collection. The healthcare provider does not need to stay in the exam room during the collection, but can certainly do so if the patient requests, and can assist with the self-collection device if the patient prefers, noting that that order would still need to be placed as a vaginal self-collect specimen. Once the test is collected and the proper ordering and labeling is complete, then as the provider, you would next manage the results. Please don't forget, you will still need to use the ASCCP app, as the past results matter toward guiding the risk-based management. If HPV 16 or 18 is found on the self-collected sample, the patient will need a referral to colposcopy. And this is true whether it's a vaginal or cervical sample, whether it's self or clinic collected. If other HPV not 16 or 18 is noted, this is the biggest difference in the self-collect world. That patient will need to return for a clinician-collected cervical pap or dual stain to guide further management or to guide next steps. Again, this is one of the primary differences. So it's really important when you're counseling your patients to ensure that they're aware of this possibility if they choose self-collect. A negative HPV result will result in a recommendation for repeat testing, assuming past tests were normal or not done. There's some difference of opinion at this point in the anticipated enduring guideline recommendation for 3-year intervals and the USPSTF draft recommendations for 5-year intervals. So I think it's safe to say it will be a 3 to 5 year follow-up following a negative HPV test. Next slide. Self-collection is relatively straightforward, and both of the devices that are approved, the Copan swab with BD or Roche, and the Evelyn brush, which is not shown here with Roche, have printed step-by-step instructions and also video options for instructions as well. There have been multiple survey studies published of folks who have used these devices, and they report overall very high levels of acceptability and say that the instructions are overall easy to understand, and they generally have high confidence levels in the ability to collect the sample. Next slide. I think this is a really key slide because we want to make sure that we are offering this option to people who qualify for it. And so in terms of who is eligible, barrier to a speculum exam is built into the FDA approval to a certain extent, in that it says that it's an option if the patient and provider decide that a clinician-collected cervical sample is not possible. Certainly, the patient needs to be eligible for primary HPV testing. So if you are following USPSTF guidelines because you need to report to HEDIS or UDS, then that would be 30 to 65-year-olds. If you're in a system that allows following the ACS guidelines, you could offer it at 25 to 29 as well. This is really a screening for average risk people who are not symptomatic. So if your patient reports abnormal bleeding, pelvic pain, vaginal discharge, this is not the test for them. And if they would otherwise qualify, but they've had active menstrual bleeding or used a vaginal product within the prior 2 days, it would be best to have them return on another day to do the self-collection to minimize the possibility of an invalid result. There are people who are definitely not eligible for this option. Those who have had cervical cancer, people living with HIV or other immunosuppression conditions, people who have had a history of in utero DES exposure. The 21 to 29-year-old pertains to the fact that if you are following USPSTF, you would not offer for that age group. And unfortunately, Medicare is kind of a side frustration, but their CMS guidelines for cervical cancer coverage were last updated in 2015, 3 years before the USPSTF came out endorsing primary HPV. And so if anyone in this audience has the power to correct that, it would be much appreciated. But if you have a patient with Medicare only and not a supplemental insurance, you'll want to be cautious about that. That's a different story with Medicaid, and we'll talk about that in a little bit. I do want to mention that per the anticipated enduring guideline recommendations around self-collection, clinician-collected screening will still be considered preferred if the patient does not have barriers to a speculum exam, and clinician-collected screening will be strongly preferred if the patient has past abnormal PAP, HPV, has had colposcopy, or pre-cancer treatment such as a LEEP or loop excision. And the reason for that is twofold. One is that there's less data in those high-risk populations. And the second reason is that many will be HPV positive if they're already in that high-risk group and would need a PAP or dual stain anyway. So the clinician collect would mean one less clinic visit potentially. but it will still be in an acceptable category for that group if the patient would otherwise decline any testing. Next slide. So self-collection is really all about expanding access to screening by addressing barriers to the speculum exam. It's better than a PAP alone and practically comparable to clinician-collected primary HPV screening. There are many barriers to speculum exam that have been reported in the literature. This is not an all-inclusive list, but some of those include pain with past exams, limited mobility, so difficulty getting up on the exam table, history of sexual trauma, embarrassment, medical mistrust, or gender diversity. This is really an opportunity for us as clinicians to provide patient-centered and trauma-informed care and to potentially allow more time to address other concerns in the visit. I will note that self-collection is used as part of the screening program in many other countries, so we are not ahead of the curve in this regard, and it is also supported by the World Health Organization as part of their strategy to eliminate cervical cancer. Next slide, please. Very critical to counsel eligible patients about the potential outcomes of the self-collect test and how that will be managed. They need to know that approximately 10% of the time, we would expect to see a positive HPV result. And if that is HPV 16 or 18, we will be recommending that they have colposcopy. And frankly, that would be true regardless of whether that test result is on a self-collected vaginal or clinician-collected cervical result. 16 or 18, highest of the high risk, 70% of cervical cancers caused by those two types, they need colposcopy. If they have the other positive HPV on the Roche test report, or the listed extended genotyping other results on the slide here that you would see with a BD report, they will need to come back to the clinic and have a clinician-collected PAP or dual stain so that we can provide them with the appropriate next steps in management. Next slide, please. I really love this helpful table. I believe credit goes to Dr. Perkins for this table that explains kind of at a higher level the similarities and differences between primary HPV testing with a clinician-collected versus self-collected vaginal sample. So who takes the sample and where it is taken from is pretty much evident in the name. A speculum, of course, needs to be used for the clinician-collected sample, but not for the self-collected. The lab test is the same. These are the PCR HPV DNA tests with genotyping. The biggest difference is that other tests, cannot be run on the vaginal sample. Only the HPV test can be run on that. Whereas on a reflex primary HPV cervical sample, the lab could add a PAP or a dual stain. So that being said, if the patient is comfortable with and proceeds with a clinician-collected cervical sample, you will be able to counsel them on next steps based on that result. If they have the vaginal self-collect, there's a chance that they would need to return for PAP or dual stain to be counseled on the next step results. Primary HPV by clinician collection has been every 5 years for some time now. Again, with the self-collection, that is going to be either 3 years or 5 years, depending on final recommendations from the different groups that weigh in on this. And both of these tests would be considered more accurate than a PAP test alone. Next slide. I did want to share that the NCI is sponsoring a research trial called the SHIP trial to evaluate whether self-collection HPV testing in a home environment is an acceptable alternative to clinician-collected samples in the healthcare setting. Again, home-based collection is not yet FDA approved. This is a multi-center study across the United States reaching underserved and underscreened populations. So do stay tuned on the hopeful eventual approval of self-collection at home. Next slide. So wrapping things up and taking into consideration, what do you need to be thinking about if you want to bring this to your clinic? Next slide. The first step really is to ensure that you and your clinic have access to a lab that has one of the FDA-approved platforms. So again, the Roche Cobas test can be partnered with the Copan swab or the Evelyn brush. The BD on Clarity Lab platform is to be partnered with the Copan swab. Again, these are PCR tests that are checking for the same HPV types and including the 16-18 genotyping, but we can only do self-collect with these two lab platforms. Next slide. Primary HPV testing is endorsed by USPSTF as grade A for cervical cancer screening for 30 to 65-year-olds, which generally means there is coverage by insurers. Primary HPV testing, whether by clinician or self-collection, has the same CPT code, which is also the CPT code for the HPV component of co-testing when it's run on these lab platforms that have primary HPV approval. There was a change to the code as of January 1st, so there might be some delays in uptake of the new CPT code. I mentioned the caveat about Medicare already. And the ICD-10 codes that we use, I think we're familiar with what we use for just general cervical cancer screening with a traditional clinician collection. It's the same ICD-10 code that you would use for a self-collection in a visit. And if the patient needs to come back to have that PAP or dual stain added to complete that screening test, that should also be coded with the ICD-10 screening code. And that PAP should be a PAP that is ordered as screening. It is not considered diagnostic. It is still part of the screening process. And you don't have to have HPV reflex run on that because you already have your HPV result. Next slide. Don't forget about our favorite IT and EHR considerations. You will need to have your team create a new vaginal self-collect order. As I mentioned previously, the CPT codes are the same, whether the specimen source is vaginal or cervical for primary HPV testing. The ICD-10 visit codes are the same, regardless of whether this is a self-collected screen or a clinician-collected screen. The screening interval may need to be adjusted. So at Mayo Clinic, we're going live with this option in our Midwest practices next week. And we've adjusted our EPIC health maintenance prompts to 3-year intervals for negative self-collected HPV tests preceded by normal results. Next slide, please. All right, to wrap it up with the key takeaways. Number 1, social drivers of health impact cervical cancer screening rates, and specific sociodemographics are associated with lower screening rates. Number 2, HPV self-collection is a new screening option that may increase screening uptake by addressing barriers to speculum-based screening. Number 3, for now, HPV self-collected testing should be repeated every 3 years if negative, assuming past normal results, and using the ASCCB calculator to guide management. Certainly with other evidence and other guidelines being updated and finalized, that may change to 5 years. Number 4, a positive HPV result on self-collection would need follow-up with colposcopy for type 16 or 18 and a return visit for PAP or dual stain for other HPV. And finally, HPV self-collection testing is primary HPV testing. So the CPT and ICD codes are the same for self versus clinician collect. And so the assumption is that self-collect should be covered like clinician-collected testing. Thank you so much for your time, and I look forward to your questions.
Before we close, we do have a poll for the participants today. And I do want to just assure folks that if we're not able to answer your question in the Q&A or the chat, then we will do our best to do so in the resource roundup. So if you wouldn't mind participating in this poll to share with us your role and your knowledge and practices around HPV vaccination and self-collection. We really appreciate that. Next slide. Just a few reminders. After this webinar, you will receive an email with all the resources, the fantastic resources that have been shared today. And look for that in addition to the recording and the slide deck to come to your email box next week. And also a reminder that this is the first in the series of 3 webinars, and our next webinar will occur in the last week of March and will focus on colorectal cancer screening. More information about the details and a registration link are forthcoming. And then lastly, I just want to thank our partners, our speakers today, our partners at the National Roundtable on Cervical Cancer and the National HPV Vaccination Roundtable, and certainly acknowledge our funder, the Center for Disease Control and Prevention, who has provided funding for this webinar series. I wish you a wonderful afternoon, and thank you again so much for your participation today.